Okay guys, my name's Brian Damitz. I'm from 30 minutes north of here, Kokomo, Indiana. If anyone likes the new road, you're welcome. Anyway, everybody know what I'm talking about, the good old 31, Stoplight City. I drove through it just because I have to for, good old times. Anyway, I'm going to talk about some foot and ankle common injuries. Dr. Reuter's going to expand on some foot and ankle cool advanced techniques. So we'll kind of hit two different spectrums. Just let me know if you have any questions. I'm going to kind of hit some of the very, very common stuff. It's going to be very basic, but this is the time to ask questions because these are the common injuries you guys are dealing with. Fractures, we'll go through the talk. So when you're talking about a common injury, ankle fractures, there's a few things we consider when we're deciding what our treatment plan is going to be. So really what it comes down to is the fracture in alignment or not? Okay? That's the first thing we as surgeons look at. Is the fracture need to be fixed or not? Okay? So obviously if it can conservatively be treated, that's optimal, but there's not always the case. So what is our point of surgery with any kind of fracture is anatomic reduction and good stable fixation. So I'm just going to kind of show a couple of different cases. So here's a common ankle injury, common fracture, just a fibula fracture on the outside. So you can see it's displaced, but what is actually more important is the fact that the ankle joint is not in a good alignment, correct? You see the number 2 right there? That space there is significantly increased, which I guarantee you that deltoid ligament, which is supposed to stabilize that area, is not working. It is complete rupture. So the other choice the body has to do with those kind of injuries is actually fracture that. So either the ligament ruptures or the bone breaks. So both are injuries that would need to be fixed. Here's another example. So on the left, well, it's the same patient, but you can see that instead of the ligament rupturing, it was the bone that broke. See how the alignment is still good here, but not here. So both would need to be fixed as well. So, has anyone heard the term trimalleolar fracture? A lot of questions are, what's that third fracture? Well, it's actually the back of the tibia, considered called the posterior malleolus. So this is a CT scan that kind of shows a good example of, here's the fracture. So the rule of thumb is if it's greater than 33% of the articular surface, 25%, sorry. If it's greater than 25% of the articular surface involvement, meaning if you basically see is this section greater than 25% of the articular surface, then that in theory should also be fixed. If it's less, then you don't need to worry about it. It should be fine. So this is actually one of my patients that was a work comp patient. So this is an example. Very bad fracture. I'm surprised it wasn't an open fracture, but it was not. So she came in looking like that. So it's got to be reduced, got to be fixed. Okay. So this is after the result. So basically, she, besides the fact that it looked really bad, she only had the one fracture. Ligament damage, we fixed that, and then at the end of the case, after you fix a fracture, you always do what's called a cotton test or a hook test, and you actually pull on the fibula after it's been fixed, and you actually try to look at it under live x-ray or fluoroscopy. And if you're pulling on it and you see widening of the space between the tibia and the fibula, then that's indicative of a syndesmotic injury, if anyone's ever heard of that. Some people use a screw, some people use what's called a tightrope. I actually prefer a tightrope. I believe this was one of those, middle of the night, not everything was exactly available, and so I use a screw, and then the screw comes out later. The tight ropes are actually beneficial because those usually can just stay in and you don't have to touch them after. So, I don't know how many people have had an ankle fracture case that the person had to take the screw out 3-6 months later. That's a lot of cost, right? And that's a whole surgery to remove a screw. So that's where we try to use kind of newer technology. I don't know what the numbers would be, but that's a significant increase in cost to the work comp world, is having a screw removed, right? So another common injury are Achilles tendon ruptures, all right? So the thing about an Achilles tendon rupture is they're almost always obvious, because the person will say, I actually had a lady, she was jump roping, and some kids were playing soccer, and she was jump roping and she ruptured her Achilles tendon. She turns around and starts yelling at all the kids, what are you doing? You kicked me with that soccer ball. She was convinced that the kid hit her with the soccer ball in the back of the leg. People think they get shot. People will say, I've never heard an Achilles rupture, but I would love to. Unfortunately, I hope it's not me. Anyway, so it's a very obvious rupture. There's chronic and there's acute ruptures. So we're talking about acute ruptures. The guy or girl was doing this. I actually had a guy pushing a plane. They're always just weird stories. So yeah, he was pushing his plane. I'm like, well, that's pretty cool. So once again, when you have an Achilles tendon rupture, you got to fix it. There are conservative measures. I personally do not like conservative treatment. That requires serial casting. I personally think it doesn't ever heal as well, and I think the recovery is much longer. So I just go for, hey, let's fix this. This is my case. That picture is not coming up as well, I'm sorry, but you can actually see on my pickups, you can actually see the whole entire circumference of the tendon. But what happens is, when an Achilles rupture, we always call it looks like a mop in, because all the tendon basically looks just horrible. It looks like it's been chewed up. So you have to clean that up. And so when you clean that up, you're losing a little bit of the length of the Achilles tendon. So that's why I prefer fixing them, and I also prefer looking at them. There's percutaneous approaches, there's minimally invasive approaches, but I have to debride that tendon, and I can't do that percutaneously. All right? So Achilles tendons are easy to fix. It's just putting one end back to the other. So if anyone wants to see, we can go through and actually simulate a rupture and talk about the repair. And the way you repair them is you can use, different people have different techniques. They all pretty much do the same thing. So everybody heard fiber wire? Do you guys know what that is? Sorry for using brand name. I don't know if that's not cool, but anyway, fiber wire is a product that surgeons use, which is non-absorbable and strong. You could probably hang a few people off of one fiber wire. Reuter, do you know how many thousands of pounds? Like 3,000?
Somewhere close to that.
Yeah. So
You
it cuts your glove. It cuts your hands through your gloves, and it doesn't cut the glove, which is good. But anyway, so this is fiber wire. Use a technique. Most people have a modification of these techniques, but these are the common techniques. Essentially, what you're doing is you're running a stitch down one end, basically trying to catch as much of that tendon as you can, and you do that on both ends. And this is an easy surgery. It's so easy. Because all you have to do is stitching, and then you have strings that come out of each end. This is the fiber wire. And all you do is tie them together. But it's done. Then there's other techniques for chronic ruptures where you can actually augment the repair with products that are out there. You can actually, certain situations, the Achilles tendon is so bad that you have to debride a significant amount of the tendon, and now you're going to fix it, and they're going to come out looking like that, which that's months and months and months that you just added to their therapy. Newer techniques have developed where you can actually do turn-down grafts, where you actually use the proximal portion of the tendon to repair through that gap. So if anybody wants to know any more specifics, let me know. But now, very common, very, very, very common. And I'm going to step on my soapbox for 5 seconds because I always do with this because it makes me so angry, is when you guys have patients that twist their ankle and go to working, well, I won't use that, but when they go to a workers' compensation, employee health facility, 97% of them I'm sure are fine. But I see those other 3% that were mismanaged and mistreated. And I end up having to go in and fix ligaments that I would not have had to fix if they came to me in the first place. So I'm very, very, very aggressive with conservative treatment. And I'm just throwing these numbers out there because I have no statistics, but I would love to go through and look back. In the last 3 years, I would probably say about 95% of my acute ankle sprains proceed on without surgery and never need surgery. So, however, I can tell you the person that comes in that says, I sprained my ankle 3 months ago, or 6, or 1 year, or 2 years, that person, the first time I see him, I'm getting an MRI. Okay? Almost always there's chronic rupture, there's instability, patients are just not doing well. They were mismanaged usually, just not aggressive enough, and they end up having to have surgery. So that's just a real pet peeve of mine because it's not just in work comp world, it's the whole thing. It's sad because if you go to the ER, say you twist your ankle playing soccer, mom and dad take you to the ER, they want to make sure it's not broke. If it's not broke, you're getting kicked out of the ER. Get out of here. But if you broke it, even if it's a little tiny avulsion fracture, oh my God, you got a fractured ankle, you need to go to the orthopedic doctor like within the next 30 minutes. You need to see him now. So it's just such a, there's education that needs to be done to the people that are treating these acute injuries. Because I think if you twist your ankle bad, they think it's fine. Because everybody's twisted their ankle and they're fine in a few days. Well, the people I see, those are the people that didn't do fine. And that's a lot. It's the number one surgery I do is ankle reconstruction. Ligament reconstruction. So, there's 3 ligaments in the ankle. They're in order of which one's ripped first, usually. That's a picture of the most commonly injured ligament in the ankle is the ATFL. Then you go down with the CFL and the PTFL. And so these 3 structures are what stabilizes the ankle. And some people have acute injuries to them, and some people just have chronically weak ankles. You ever hear people, I have weak ankles? Well, I see so many athletes, it's ridiculous. Gymnasts, they're all girls. They're all about 14 to 16 years old. And they come in, I twist my ankle once a month. It's been going on for years. And I'm finally sick of it. And the parents are like, she's fine, she's gonna be okay. But the kids really, they're just, like, they're the 14-year-old girl that will, I have a lot of respect for gymnasts, let's put it that way. Because they are badasses. Excuse my language, but those girls are like major athletes, and they have serious problems with their ankles a lot of times. And you go in and you can actually see, when I open it up and I can actually see the ligaments, sometimes they're intact, but they're really stretched out, and they're pretty much worthless. And you can actually manipulate the ankle in the OR, and you'll see just major motion. And so it's a really fun and cool surgery because you can actually see immediate results. You tighten those ligaments up, you can do the same manipulation, and it's solid. And so immediate rehab after a few weeks of non-weight bearing, and then they do very, very well. So, sorry, I'm still on my soapbox, aren't I?
What thing, and in the work comp arena, how long before return to work, full duty? Because I think of these reconstructions as being pretty long-term recovery.
Yeah, so I split them off from the OR 2 weeks, take out the stitches, put them in a boot, and start range of motion. And then they do another 4 weeks of non-weight bearing. So that's 6 total. 6 weeks total. I've actually, in the last probably 6 months, been going down to 5 weeks. And all my patients are doing fine. So I'm starting therapy at 5 weeks. And all the therapists that see my patients, they all know. I've told them, I'm not going to give you rules. but you kick my patients' butts. I want aggressive kick your butt therapy, and don't be a wuss.
At 6 weeks.
Oh yeah, 5.
Wow.
5 now.
5 weeks, sorry, yeah.
So yeah, at 5 weeks, we're starting therapy, and I would say within a month, they're usually, we have a lot of mill people up in Northwest Indiana, so a lot of our work comp injuries, it's really tough to get them back to work because they can't go on the property without steel, metatarsal boots. So, but if it was Joe Schmo, who was just a sedentary job, they're back pretty much right away. So as long as they can have a splint or a boot on, they're working. So, any other questions about? This is the time. Any common, normal, everyday, typical ankle, foot, and ankle stuff. Does anybody have any questions about anything? Okay, so this is just an example of the repair. It doesn't really matter what we do. But what we're using is we're tightening the ligaments, but we also use part of the tissue, which is called a retinaculum, and we use that retinaculum to actually further augment the repair, which makes it even stronger. This is a type of device that will actually, quote unquote, rebuild a ligament as opposed to reconstructing it. So this is the same material I was telling you about, fiber wire, but it's attached to 2 anchors, and so that's recreating the ligament. The one negative about that is sometimes if you over tighten it, it's not going to stretch out. You can send them to therapy for 100 years. That's not stretching out. So if it's too tight, you're going to have to go in and take it out. All right, so we all deal with metatarsal fractures. What's the most common?
How often do those screws work themselves out in that joint? Never happen at all.
No. So there are also, the guy was mentioning PEEK. I believe they're made of PEEK, but I do know that they absorb within 2 years. So they shouldn't be moved. I mean, that's just bad technique if they move out. So who's heard of Jones fractures? How many do you think are you guys usually seeing people do surgery for those? Yeah?
Yes.
Okay. So I'm very conservative when it comes to Jones fractures, and I treat them conservatively. 6 weeks in a cast. All my patients do really well. Bone stimulators are helpful, so I know you guys hate bone stimulators because they're really expensive, but in this case, in Jones fractures, they're very important. So with a cast and a bone stimulator, I've never had a non-union, and I've been out in 3 years, for 3 years. In 3 years, I've done 1 Jones fracture surgery, and all of mine are conservatively treated, and they do fine. So take that for what it's worth. However, if you are going to do the surgery, you're going to go in and you're actually going to drive a pin or a K-wire into the 5th metatarsal, and this is the guidance system that they use. So once you have the pin aligned, and you're going to confirm that with x-ray, once the pin's aligned, you just throw a screw right on top of that, and basically some of the newer systems, they found that these screws do take a lot of stress, so in order to throw it over a pin, it has to be cannulated, which makes a screw weaker than a full screw. So anyway, there's systems out there. Basically, the whole point is put a screw across it, get compression, and in theory, it should heal quicker. Here's a common crush injury at the mill. We see so many 500-pound beams or 1,000-pound beams, or huge steel plate fell on my foot, and so we get these kind of injuries where there's multiple. It's a polytrauma. So you got 2nd, 3rd, 4th metatarsal fractures. These are all displaced, so something like that would need to go into surgery as well. So how many people have had calcaneus fractures? Everyone. How many times do those patients have surgery and then they progress through therapy and they go back to work and they're happy as a clam? None of them. Right? I would break every single bone in my body before the calcaneus. And it's just because there's a lot of morbidity with those fractures. It's a very tight and very sophisticated and very hyper, it's just a weird joint. And all the calcaneus fractures almost always involve the joint, so you got cartilage damage. And I always tell patients, I can put your bone back together, but I can't fix the cartilage that broke, because that cartilage broke. So that's guaranteed that that cartilage is damaged. Cartilage doesn't heal very well if it does at all. So you end up with subtalar joint arthritis. Well, what's the treatment for subtalar joint arthritis? Unfortunately, it's a subtalar joint fusion. There's no replacement for that joint. So to go in and fuse, I was going to talk to you guys a little bit about just the fact that I'm sure you've learned this, but calcaneus fractures, they're always tough to treat. It's pretty funny because you'll see a lot of people, they'll treat ankle fractures all day long, but nobody wants to treat calcaneus fractures. And so I've kind of become that guy that does the calcaneus fractures. And so they're all different, they're all complicated. The dissection's pretty tough. It's a very tight joint. It's hard to see the entire fracture because it's such a, I mean, you're talking about looking inside the foot. The whole entire heel bone is broken. So, who has questions about calcaneus fractures? Anybody? Any other questions? We'll go to the lab and have fun.
Liz Franks, are those conservative or do you always have to surgically fix those?
Well, a Lisfranc fracture or dislocation or whatever you want, they're kind of same terminology, but those kind of fractures do much better with internal fixation. And there's a lot of theories between some people actually go in and fuse the area after an injury, and some people just put a screw across it. Now think about it, you're talking about a displaced joint. So it's not a true fracture, but it's a displaced joint. Now you're putting it back together and putting a screw across that. You're screwing a screw through good bone, through good cartilage, through another good cartilage into the other good bone. And now you're telling, and you're not fusing it, so you've got a screw going across a joint that's not going to fuse because it has cartilage. That screw has to come out later. It has to come out. Some people will let it break, but I think that's crazy. And so what damage did you do to that joint? You know, iatrogenically. So does that answer your question?
Yeah.
I mean, those are also complicated.
It's
But
bad all the way around, aren't they?
they are.
They're always painful
Well,
afterwards.
the worst is not just when you get a complete, like, so we're talking about this region right in here, okay? So the Lisfranc ligament runs from the second metatarsal base to the medial cuneiform, right there. So you can actually see whenever there's a Lisfranc dislocation, you'll actually see a significant gapping here, okay? And so that means the Lisfranc ligament has completely ruptured, and that's why we put a screw. We get that joint back together and then throw a screw and hope that ligament heals underneath. But then you get all kinds of variations where, okay, this whole entire joint is dislocated, so you're talking about major, major surgery. I had a kid, football player, who was probably 150 pounds, you know, soaking wet, and he got crushed by like probably 300 pounders. His whole foot was dislocated. Like pretty much every single bone in the foot was somewhere it shouldn't have been. And it's very interesting because I was like, oh my God, I'm only 3 months into practice. Oh. But I'm going in confident. Yeah, let's do it. So I'm like, what am I going to do? I've got all this A, B, C, D, E, F, G, H, I, J, K in my brain of plan. And I go in and I was like, and I did this after he was under anesthesia and it went right back into place. It just, like it all wanted to go back where it belonged. And I just threw a couple pins. Kid sent me a letter 1 year later. He said, I run every day. I'm having no pain. He's like, thank you. So it was pretty cool. But they're all different. So that's the problem with the foot and ankle is a lot can go wrong, and it's a lot of small little tiny joints and ligaments and tendons and all that fun stuff.